morning, everyone. A very good morning. And thank you so much. Well, it's really heartening to see we are able to start session at 9 o'clock. So, welcome to all our urology colleagues who have traveled and also our nuclear medicine colleagues who have traveled not only from Haryana, even from outside India. Thank you so much for being on time. So, we are starting the session. Good morning, everyone. It's very warm welcome. So for the first session, I would like to invite the chairpersons in the front seat. Dr. Rajeev Sethia, Director and Head Urology, Kidney Transplant and Robotic Surgery, Asian Institute of Medical Sciences, Faridabad. Dr. Rohit Kathpalia, Consultant Urologist, Dr. Rohit Kathpalia, Urology Center, Karnal. Dr. Vandana Dhingra, Professor Nuclear Medicine, AIMS, Rishikesh. Dr. Sunil Mittal, Consultant Urologist, Sri Hari Hospital, Karnal. Dr. Arun Jindal, Consultant Urologist, Sri Hospital, Rohtak. Dr. Arun Sasikumar, Managing Director and Chief Nuclear Medicine Physician, Swasti PET CT Imaging and Nuclear Medicine, Jindal. And Dr. Vaibhav Gulia, Consultant Radiologist, Kathpalia Hospital, Rohtak. For the first lecture, I would like to invite on stage Dr. Scintillating Way, who is Associate Professor of AIMS Jodhpur, and his areas of interest are nuclear cardiology, oncology, and urology. He'll be taking up renal cell carcinoma, roller PET CT.
Good morning, sir. So I'll be talking about role of PET CT in the renal cell carcinoma. So before I begin, I'm glad to thank Dr. Arun Kundu for inviting me to the CME. And I must say she is a very wonderful host and interest into personally in every guest is awesome. So thank you, Dr. Arun. So I have been given the responsibility of opening the evening. At the same time, there was a disclaimer that I have to play like a novel. So let's see if I can accomplish it in 12 minutes. So we'll discuss this under this setting, some basics about renal cell carcinoma, imaging in renal cell carcinoma, then utility of advanced PET CT in renal cell carcinoma, and see some cases, and finally some newer radioassays in RCP. Right. So RCP, as we know, this is the most common malignancy of the world, and it is derived from malignant tubular epithelium. Most of the time, RCP is occurred, and when symptoms appear, it is mostly the advanced state of metastasis, and the classical diet is only seen in 10% of the patients. Mostly these RCCs are incidentally detected and patient had therefore imaging for some other purpose. And at the time of diagnosis, only around 70% are in stage 1 and 12% are in stage 4 disease.
You said that sitting CCT is then just the only batch. So if CCT is showing that no body mass spotted can be fine, should we go ahead or me or partner that the key or should we get PET scan?
So depending on our clinical suspicion, if we suspect it is metastatic or advanced disease, so it is better to do PET CT because we have both the CCT part as well as the metabolic part with the FDG. So we can give information which will be given on CCT as well as the metabolic status of the lesion. So, and for bone marrow, yes, FDG PET CT is better than CCT. It may not be picked up on CCT.
How to decide actually get the PET detect the body mass body?
Generally, when there is a large mass and if we see a large mass duration of a symptom, it is generally advanced stage. So, in such patients, it is better to do the FDG PET CT.
Lecture, I would like to invite Dr. Puneet Sharma, who will be giving us lecture on adrenal mass role of PET CT. He is Senior Consultant and Adjunct Professor Nuclear Medicine of Apollo Multispecialty Hospital, Kolkata, with areas of interest being molecular imaging, cancer imaging, radionuclide therapy, and diagnostics.
Well, thank you all the writers, especially Dr. Arun, for inviting me. So I will be talking about what role can PET CT play in the evaluation of adrenal mass of adrenal tumors. So we can divide adrenal tumor into 4 types: functional ones and incidental ones. Functional account for around 15%. Okay, this topic, thank you. on 15%. And in these patients, the detection is either by physical symptoms or biochemical evaluation or imaging. And then in these patients, most of the patients we need an appropriate functional duration. But for incidental tumors, which account for around 85%, we have to decide whether functional imaging is needed or not, and whether just conventional imaging is. So that's how we work as a child. CT and MR are usually the first investigation, especially CT. A non-contrast CT, just an MPPT and outbreak unit will rule out most of the tumors as benign adenoma, and those which remain indeterminate even after that, then you do a adenosurgery, see the washout. If it's still unclear, we usually do an MRI, and then based on that, you rule out the lipid over adenoma, and those tumors which remain, their patient CT can play in the yeah. The actual functional imaging from a nuclear medicine point of view, previously we had displaying agents like 123 or 131 MIBC, which was the most common one used for pheochromocytoma. Then we have hydrotol, corticosteroid, and 59 scintigraphy. But these have become more and more redundant because all of these have been shown to be video CT imaging, which we currently have. Then there is a supply issue with the reservoir article is not available easily and it's costly. Costlier than a PET CT. So these have become more redundant, and we are moving to functional imaging using PET CT, which provide a personal and anatomical evaluation. They have a high activity and specificity, and compared to deep imaging, even the availability is much more widespread for imaging of adenomas. So, what are the different pathways we can target with PET CT for adenoid tumor imaging? So we can target the tumor metabolism with FDG, which is the most common tumor agent. Then we can target the somatostatin receptors, either with the gadget-labeled or protein-labeled compounds, and these are mostly used for pheochromocytoma. Then we can target a TOPA-hydroxylase pathway, which is again useful for pheochromocytoma imaging. Then we can target the chemokine receptor 4 pathway, and which using the compound the pentoxicol. And this is used for evaluation of adenoid tumors, especially aldosterone secreting adenomas. And then we can also target with so we target the adenocortical enzymes which are involved with secretion of adenoma with the compound like the metometed, which is not widely available, but for completion with the habits. So FDG PET, we know that malignant tumors will have a high uptake of it. Benign tumor, if you want so benign but with malignant retinal nodules, FDG PET CT can be used. Especially patients who have a known axillary malignancy, most of these patients present FDG PET CT, and we know go for biopsy or excision. For adenocortical carcinoma, again, FDG PET CT are shown to be useful for staging, restaging oncologic spondyloarthritis, and infection presenting with adrenal mass. There also FDG PET CT pattern instead of immediate parts. So where does PET CT comes in the workup of adrenal segmental one? So if you have a typical benign feature on CT, so nothing to be done. For indeterminate tumor where CT is inconclusive or indeterminate, there your differential become a metastasis, a PO or HCC or lipid poor adenoma, and there PET CT will have a definite role. This also becomes important because unlike for other tumors, biopsy is mostly contraindicated for adrenal tumor. So that's why a non-invasive imaging in the form of PET CT is the best. And if the mass is more than 4 centimeters, if it's a known malignancy, most of these patients will go by PET CT rather than a biopsy. And if it is in more than 4 centimeters, no malignancy, usually they will go resection, but in clinical practice, most of these patients undergoes PET CT first, and then based on that, they plan for a resection around. And now coming for functional adrenal tumors, so if you have a pheochromocytoma, you can use either a fluorodopa or if you stay on PET CT. If it's a primary aldosterone, you can do a radiopharmacy, and if it's hypocortical secreting tumor, usually do an FDG PET CT because they are included a lot. Well, so that's how we can integrate a PET CT in the management of conditions. Now, thank you very much.
Now for the next presentation, I would like to call Dr. Jaspriya Baru, Hospital Scientist in Delhi, with areas of interest being molecular imaging, oncology, and therapeutic. I'll be taking a non-oncology topic, but a very pertinent topic for the genitourinary system. And I'll be focusing more on the PET part of it. Let's start with an interesting case. This is an image of an elderly female who had targeted breast cancer. She was a CKD patient, She was on letrozole while imaging for the response evaluation. There was a large inguinal node that she developed. The biopsy was done from the inguinal node, which turned out to be lymphoma. Being a concomitant to malignancies case, she was on regular follow-up. When we saw these large bilateral renal lesions, which were intensely FDG aware. This was interestingly, when biopsy was done, the biopsy showed NG bodies, which are nucleus witness bodies, a very typical feature of a renal melicoplakia, which is seen in the CKD patients, a rare condition, rare infective condition, but treatable by antibiotics. So, few courses of antibiotics. When we saw serial scans, the renal lesions disappeared.
So,
So nuclear medicine for infection and inflammation is widely accepted, increasingly being used for diagnosing and treatment monitoring. It is exemplified by the numerous recent guidelines in which PET imaging is now part of the diagnostic flowcharts. Morphological imaging like ultrasound, CT, MR, they are commonly used, but they focus on morphological changes, tissue distortion, which we often see at later stage. Functional imaging helps with detection of the functional changes which are there already at an early stage, and we are able to evaluate treatment response at an early stage as well after a few days or maybe few weeks. So this is a large spectrum of the genitourinary infection inflammations that are seen, and because we routinely do FDG tests for other causes, these are more often than not some incidental findings that we see then.
Is better or the BBC scan and usually to show the many.
So because we can actually localize in the whole body, and lymphocytes can still have a lot of physiological uptake in the other organs also, but FDG is better for as of now. It's better than the other infection. To call Dr. Sethia now to present a lecture on urinary bladder malignancy role of PET CT scan. She is consultant in nuclear medicine, Tata Medical Center, Kolkata, DAT faculty, LV board, IIT faculty, course of MSc, MM. Thank you everyone. I would like to thank the organizers, especially Dr. Kathpalia, for giving me this opportunity. So my topic of presentation will be on PET CT carcinoma bladder, and not a very much recommended area that we get for lungs, breast and prostate and lungs. So bladder carcinoma happens to be the 10th most commonest cancer, accounting for 3% of global cancer diagnosis. Most commonly seen in elderly males with a risk factor of tobacco smoking and exposures, including occupational and environmental exposures with some medications as well. So the basic the layout of classification was done in 1973, followed by modifications in 2004 and 2016. So the most common type of bladder cancer is the transitional or genitourinary carcinoma, which accounts for 90% of bladder carcinomas, and the typical ones being the papillary. And then there are the other types of non-papillary. So this was actually previously named as histologic variants in 2004, and now this terminology has changed to subtypes in 2016. And the other non-transitional types are classified and named as divergent differentiation, which includes squamous, neuroendocrine, mesenchymal, and adenocarcinomas.
Right.
So we can classify papillary, the most common urinary carcinomas, into grades. So grade 1 encompasses the papillary urinary neoplasm of low malignant potential, which is, so we can see this 1973 and then 2004 and 2016. So grade 1 is PU and LMP, and grade 2 is the low grade ones, and high grade comprises of grade 3, which is the high grade papillary urinary carcinomas, and grade 4 is the urinary carcinoma in situ. So the staging from the stage that is AJCC, AYCC, 8th edition, and this is a total representation. So anything from T2 is muscle invasive, and why this has been divided into muscle invasive and non-muscle invasive. So I would like to say that we can classify it as grades, as I said earlier, depending on the cellular atypia, and we can classify it as invasive on the basis of invasiveness as non-muscle invasive and muscle invasive bladder carcinoma. So why this classification? Because The treatment is different, and muscle invasive bladder carcinoma happens to be more aggressive, so we have to treat it with radical surgery and chemotherapy. So a patient generally presents with hematuria, and then the investigations include urine analysis and tumor markers and cystoscopy. So once cystoscopy detects lesions, the duality is done. If you don't find lesions in cystoscopy, you have to follow it up with random biopsy and urine cytology. And when the lesions are present, so the basic primary staging is done from QRBT itself. So on QRBT, we have to now classify as non-muscle invasive, carcinoma in situ, and muscle invasive. So in case of non-muscle invasive, we generally go with BCG doses, and the amount of doses depends upon the grade. And in carcinoma in situ, the same thing follows, but if there's recurrence, patient might end up having radical cystectomy with adjuvant chemoradiotherapy. Coming to muscle invasive, so muscle invasive, I'll be discussing it later on also in details. So let's talk about the imaging first. So till now, a patient was done on UIVT and the lesions are present, detected. So the modality of choice remains to be CT abdomen and chest, because with only drawback of not detecting tumor size than 1 centimeter, with the nodal sensitivity still better compared to MR. But MR will be better in evaluating tumors at the base and low of the bladder. And so also talking about the extravesical tumor extension and surrounding organ invasion. And I will be discussing on the role of FDG PET-CT under 6 heads. So coming to evaluation of primary tumor, as I already said, that URBT itself will give us the idea about T-staging, and the basic drawback is that FDG is having renal elimination. So what are the ways that we can reduce, FDG, the visibility of FDG in the urine while we see the lesions? So the methods include oral hyperhydration, catheterization, dual phase imaging, taking an early phase and taking a delayed phase, and forced dialysis and bladder education. And the meta-analysis showed the sensitivity and specificity to be good, but still it has not been recommended as one to be using for primary tumor. So this was a study where the role of density after diuretic administration had shown detection of more number of residual lesions in the bladder. Coming to lymph node staging, yes, there is some role of PET-CT here, and because CT and MR have shown lesser sensitivity and specificity compared to FDG PET-CT, and PET-CT has shown will change the clinical management also to upstage patients. So this is the article, systematic review and meta-analysis, where they are detected, the sensitivity or specificity of 0.57 and 0.95, and it was more accurate than CT alone. And this is an integrated analysis where they have compared FDG PET-CT with CT alone, and they have said that combining SUV and axial-based lymphocyte criteria, FDG has improved the better diagnostic accuracy for preoperative lymph node staging in patients with MIBC. And again, another one, performance of lymph node staging with pathology, the gold standard, and that compared sensitivity, specificity, accuracy, and you can see the higher values of PET-CT each and every time when compared to CT.
Here, nuclear medicine PhD, Dr. Rajeev, Director, UMed Hospital, and Chief Consultant and MD and CEO, FD Diagnostics, UMed Diagnostics Bengaluru, with areas of interest in clinical nuclear medicine therapy.
So basically, the kind of opportunity to have for renal nuclear medicine, both are in front of you. This is what learning what I went through in last 20 years or so, both from the space as well as outside when I started practice. So before starting, just one slide on concepts. In nuclear medicine, we use short-wave radio tracers, technetium, gallium-68, and so on. We label it with different pharmaceuticals. The way body handles that organ, that radio pharmaceutical, we use it for different organ regions.
like to invite our chief guest, Dr. M.P. Lotasan, to share a few words with us.
Yeah, I'd like to thank the organizing committee for giving me this honor to be the chief guest for the inaugural function for this conference. I'd like to mention that when I joined in 1975 in the Indian Institute of Medical Science, at that time, nuclear medicine department used to be in the ground floor and on our books were there at that time. And I'm happy to see the growth of the nuclear medicine along with all other branches of the medicine. The kind of the inventions have been done for the imaging as well as the diagnostic and therapeutic both sides actually, and this is very heartening. Normally with the imaging like ultrasound and CT, we have the anatomical study, and for the functional imaging, I think so the nuclear medicine plays a very important role. Only I like to say that we have to always think from patient point of view. As a clinician, I'm mentioning that, and we should know when to get which investigation, because now there's a plethora of investigations available for everything. The cost of the treatment is equally important. So the physician should know where is the indication for a particular investigation and what we want to expect and how it is going to change the treatment of the patient. But that should be the motto of getting the investigation, not just for the sake of getting these investigations. Now there are some problems also in diagnostic side that because of the PET CT, which I know more of the PA prostate and all that, there can be overstaging of the disease also. The second thing is sometimes it is not possible to differentiate the etiology of that lesion, maybe inflammatory, maybe metastatic. Then sometimes we have to do a biopsy to confirm whether there is what kind of lesion is that. So that is also equally important, so that it should not be overestimated or underestimated like that. And last thing is I'm very happy to see that in a town like Rohtak, such an excellent facility is available both in private and government sector to have these nuclear medicine. Because I remember in a lot of institutions, in the medical colleges and all that, these studies of the xenogram and all that, even not used to be available. So they used to operate on these patients on the basis of the IVP of intravenous Kathpalia obstruction I'm mentioning. So like that, the treatment was going on. But I'm happy to see that last kind of growth has taken place even in a town like Rohtak, a smaller town in the country. But that shows the depth of the development for the medical science all over the India. With these words, I like to congratulate the organizing committee for organizing and giving this new thought of the nuclear therapy program, and which is very useful. Thank you very much.
The first two presentations will be on PSMA PET CT and PSMA PET CT indications to cases.
Good afternoon, everyone. At the outset, I want to thank Dr. Praveen Kundu and the organizers for the ICNM. So basically, Dr. Sasikumar, his senior, he was supposed to present the first presentation. I think he had to cancel both of the presentations, so I will be presenting both. And I have clubbed both into a single presentation. So basically, on our work we have done over the years on PSMA PET and what are the mistakes. The first topic was how early can you use PSMA PET in the diagnostic algorithm of prostate cancer. So after clinical assessment, collector examination, urine culture, sensitivity, we get a serum PSA done, and the level say on an average more than 4 is considered a bit suspicious for possibility of pregnancy. But they don't just know better than us that, so there are multiple flaws in that. So the overall sensitivity of PSA is in the range of 60s to 80s, the same regarding specificity. So there are around 30% of cases which can be false. And the issue is which imaging helps in the diagnostic algorithm of suspected prostate cancer is that you don't want to risk prostate cancer on one side. But on the other hand, also you want to avoid unnecessary biopsies and their compensation. So imaging in prostate cancer includes anatomic imaging, the transect ultrasound, the first one, the basic parametric MRI, when we are suspecting the cancer and its role is quite well established. TT for staging, if it is confirmed. In the molecular imaging heritage, gamma camera used to be one of the most commonly done flavors investigations for prostate cancer stages. Now, among the PET tracers, in the last decade, TSM PET has come up. Although it has been in development for the last more than 5 years, so what we are seeing today is the development of the last few decades as PSM PET CT has come to the forefront of prostate cancer imaging. So this is a picture of a bone scan, just say here with the suspected metastatic prostate cancer. So PSMA per se is a name which has been given to transmembrane protein which is present on the critical epithelial cell on the cell membrane as well as internally in the cytoplasm of these cells in the prostates. So it's basically an enzymatic activity which is a folate metabolism activity. So it's involved in folate metabolism, and as we know that folate metabolism is increased in cancers and antifolates are used to treat cancer. So that way, in that way, it's a marker of cancer. So this is the shape of this transforming activity on the cell member. And what we get is the end result is this image, which is a on-body MIT image of a PSMA PET scan. So this PSMA, along with folate, it is also involved in glutamate metabolism, and the name is PSMA. So again, that is subject to discussion. It is significantly overexpressed in up to 100 to 1000 fold on in 95% of the prostate cancer cases. So in 5% it is not overexpressed, so that is one thing, it's not a 100% thing. And the expression of PSMA is further increased in advanced cases on androgen activation and metastatic CRP cases. So whatever pharmaceutical we are giving, we are trying to this extracellular domain on the prostate cancer cells, and they are internalized, which helps to erase them as well as treat them using PSC. Using functional guidance using a transluteal route, even trying a transcranial route, but that is much more cumbersome as compared to this simpler transluteal approach. And we organized a couple of workshops to teach this process to our colleagues, and now multiple centers across India actually are doing this procedure.
Why the long past we have put a not the short past we get you professionally so that
It's a
is it because you're more used to that?
we are more used to that, but transcranial per se is more painful, more time consuming, difficult to do. Especially the lithotomy position kind of position is difficult on the scanners. Even abroad, the centers which most centers don't do, even PDA doesn't do MRI transcranial biopsies. So most centers they do abroad, they do like 2 cases a day. So the basically the radiology control is a minor OT kind of setup. The system is really blocked up for the full day.
And support that you doing such good work. If you draw the urologists, more and more urologists are now shifting to transcranial biopsies. She's able with the local mixing to do the biopsy. That's, I mean, just like there was a Brexit, there was a movement towards classic with something was
Yeah.
so like Brexit was protected. So maybe what's a shorter route and local anesthesia definitely.
Yeah, but I think the local, it's more renal is a more painful area to enter, and difficult to sustain that we can doing at least when we are doing the guidance using MRI or PET.
Probably the concept in a say no.
Even the time taken, we did a couple of cases. Obviously, the initially learning curve is more, but took more than 1.5 hours or so. This translutal, depending on we have a vertical guidance for that. I think in the next talk, Dr. Not will talk about it. So I think he can delve more into it. So in that, basically, it can be done like in 10 minutes also. So if you have quite experience, it's much more comfortable with it.
It's good to see you doing such work in the full work there. Music, thanks.
That's our department. Thanks.
So the second session, the second lecture of this session, that is on prostate biopsy or of nuclear medicine. I would like to invite Dr. Arun, who is consultant in Nuclear Medicine Command Hospital, Lucknow.
Okay, so first of all, on this outset, I would like to convey my thanks to Dr. Praveen and all the organizers of Arun Diagnostic Center as well as Haryana University Association. And since morning we had a huge discussion of academics over diagnostics, therapies, as well as now we are entering into nuclear medicine. So a lot of questions have already been given by audience as well as the person. I would like to cover all those topics in my presentation. So, first of all, I would like to say what are the challenges while we are doing image-guided biopsies. Number one, transrectal ultrasound. Biopsy guidance and brachytherapy replacement it has been used. Limitations in differentiating normal prostate gland from cancer tissue is still there in such time. And biopsy is not specifically targeted to areas that are most likely variegated. Sometimes it may miss. Now, other image-based biopsies by non-invasive means, they have an integral role in the management of prostate cancer, and images should be there that depicts the site of cancer burden. Okay, so as it was pointed out, high PSMA expressing site means high cancer burden, already pointed out by my seniors. And integrated diagnostic scheme should be there so that we can biopsy those targeted high cancer burden images. And that particular information should be applied for guiding us towards the biopsy tissue in sampling. Now, see, conventionally we have a lot of approaches: blind biopsy, separation biopsy, and image-guided biopsy. There are different biopsy methods that have already been routinely performed. So the most common was, as pointed out by Dr. Pranay, transrectal ultrasound guided usually takes 12 folds. Okay, increases the likelihood of detecting prostate cancer. So 12-fold biopsy, you have to target multiple samples from different folds. Okay. Then there was a transperineal biopsy already pointed out. Some clinics use transperineal approach where the biopsy needle is to be inserted through the skin between rectum and scrotum. Can be painful. Then comes MRI guided biopsy. MRI guided biopsy, which use MRI images to target suspicious areas. Of course, MRI has proven its strength in the T staging, and this can be a good approach. Then, sextant biopsy. Traditional sextant biopsy involves 6 folds, but 12-fold biopsy is better. Okay, and we have also gone to literature which says super saturation fold biopsy, 24-fold biopsy. So that gives a better result. Now, limitation of traditional 12-fold biopsy at the usual method is false negative rate up to 30%. Sometimes overdiagnosis in a low risk cancer, sometimes underdiagnosis in a high risk cancer. So, in blind prostate biopsy, approximately 1/3 of the prostate cancer can be overlooked. And furthermore, in 1/4 of the cases, Gleason score is lower than actually it is, which means it may appear as less aggressive, however, it is not really, and which will result to a delayed or unsuccessful treatment for the patient.
First is like in the routine we do PET CT, the PSMA PET after biopsy toward prostate cancer. One sorry recommending that after a suspicious MRI, PSMA PET should be the first and biopsy should be later. That is first. And my second question is what you said. Transfusions are taken only biopsy from one side of the prostate. So then the T staging is not complete. That is only possible if you are only having some focal therapy of prostate, but you need increase the staining from the type C has to be completed by later.
Yeah.
If anyone is going for radical surgery, if one side is weak, you can go nurse sparing.
Sir, I would like to answer this question by saying that still this approach is innovative approach, and in my experience, I have only done biopsy only such cases that are not yet proven.
First talk for this is what is prostate cancer, then 77 mutation PSMA therapy, when and how to use this thing. So for this, we are calling the Professor Shamim sir.
What is mutation PSMA therapy? This presentation is not for the nuclear medicine of that. This presentation is for my urologist colleague to make them understand what is the mutation PSMA therapy and what are mechanism and ways to use. So it is an highly targeted treatment for advanced prostate cancer, particularly for patients with metastatic castration-resistant prostate cancers. And it can be used for other forms of advanced prostate cancer that have spread to the other organs. So we all know the natural history of prostate cancer. It starts as a localized and it may progress to the metastatic castration-resistant prostate cancers. So we, at one point of time, prostate cancer can progress to castration-resistant stage where we need to treat the body. So there are many options which are available for metastatic castration-resistant prostate cancer, including the taxane-based chemotherapy like docetaxel, cabazitaxel, androgen receptor pathway inhibitors like abiraterone and glutamate and all, then PARP inhibitor like moratorium, and then the nuclear medicine come into the play, that is radionuclide therapy. So इसमें क्या है, we have many options for metastatic castration-resistant prostate cancer. इसी के ऊपर मैंने शेयर बोलना चाहूँगा, प्रदीप ने बोला था कि काफी लोग सोए हुए हैं, सो उसको शायद वो शेयर सुन के लोग जागेंगे भी और वो शेयर इसके रेलिवेंट भी है. उस शेयर का है ऐसे है कि जाने वाले तेरे हजार होंगे, जाने वाले तेरे हजार होंगे, कहाँ सारे तेरे वफादार होंगे, जाने वाले तेरे हजार होंगे, कहाँ सारे तेरे वफादार होंगे, कुछ जान लेने वाले मिलेंगे, कुछ तेरे जान निसार होंगे. मीन्स ये इस थेरेपी हमारी न्यूक्लियर मेडिसिन थेरेपी और बाकी थेरेपी में ये बिजनेस है कि हमारी थेरेपी जो है वो जान देती है, जान निसार करती है. जब जाती है बॉडी में जाके वहाँ डीके होती है, डीके होने के बाद रेडिएशन इमिट करती है, सिर्फ कैंसर सेल को किल करती है. While the other therapy, they will go inside the body, they will target the cancer cell as well as the other cell of the body. So they will take your jaan also, but he particularly this radionuclide acid will be its jaan on the cancer cell for the patient. So that is the basic difference between urological therapy and the other therapy.